So my name is Dr. Martin Whyte. I'm a clinical senior lecturer at the University of Surrey in the UK and a consultant diabetologist. I presented work today in the OP21 session at the EASD, looking at glycemic trajectories and their effect on subsequent macrovascular event rate. The background to this study there's been lots of data showing that cardiovascular disease is associated with ever higher HbA1c, but that if you control the glycemic level early on after people have been diagnosed with type 2 diabetes, and this has been shown in studies like the UK PDS, you can get a subsequent reduction in your chance of subsequent macrovascular disease, and that's even if your control subsequently deteriorates. That's been something called the legacy effect. But another pattern of glycemic control, which has caught a lot of attention recently, relates to glycemic variability. So the idea that if your HbA1c goes up or down to a significant degree, that's also associated with the risk of macrovascular disease. So we wanted to explore this a little bit further. So we used the Royal College of General Practitioners Research and Surveillance Centre database, which is based here in England, and interrogated it to find individuals who were diagnosed with type 2 diabetes from the 1st of January 2007 onwards. And we followed them up for a maximum of 10 years to see whether they accrued macrovascular complications. And we define macrovascular disease as myocardial infarction, stroke, peripheral revascularization, heart failure. Now, in terms of our modelling, we looked at the change in HbA1c over the first 12 months after they're diagnosed with diabetes. So we had an HbA1c at baseline, HbA1c 12 months later, and we looked at whether the HbA1c dropped down from a very poor level at the diagnosis to a good level, below 7.5% at 1 year, or whether they stayed at a poor level or indeed stayed at a good level. We had three categories at diagnosis of HbA1c and three categories at 1 year, so they could chop and change between those. So there's up to 9 trajectories over that first 1 year period after they're diagnosed with diabetes. Then the second measurement that we looked at, the Variability Score, was a calculation based on a paper by Angus Forbes in The Lancet last year, and that really looked at how many changes in H1C of more than 0.5% occurred over the follow-up period for that individual. And we then used that to calculate something called the Glycemic Variability Score. And then going to the results, what our data showed was that we had around 21,000 individuals who were diagnosed with type 2 diabetes after the 1st of January 2007. And there were just under 2,000 MACE events. Now the interesting thing that we found was that if you started off with a very poor H1C at the time of diagnosis, but that you improved to an H1C below 7.5% at 1 year, that had no increased risk of subsequent macrovascular disease compared to those who started off with an H1C of less than 7.5% and stayed that way. In actual fact, we showed that actually they seem to be better off, which is something of a paradox. But we found that those who stayed with a very poor H1C at diagnosis and at 1 year, they stayed at that level, they had a higher rate of hazard ratio of having macrovascular disease of around about 1.6. The second part of the analysis that we were looking at was the variability score. We found that those who had the highest level of glycemic variability after that 1 year period and up to 10 years had a much higher risk of subsequent macrovascular disease than those who had very little glycemic variability. So our conclusion from this study was that even if at the time of diagnosis you were diagnosed with a very poor H1C, you can dramatically reduce your subsequent macrovascular disease risk by early glycemic control, but that subsequent glycemic variability will add to that risk of macrovascular disease. Now, just a mention about potential limitations to this study, we modelled H1C trajectories using something called a time-dependent, using it as a time-dependent variable, but we only had baseline data for confounding variables like body mass index and blood pressure and so on. So what we cannot say is whether these patients, as well as improving their HbA1c over that first year, also lost a lot of weight, or whether they started on medications for their blood pressure and so on. And it was interesting because, as I mentioned just now, that those who start off very poor H1C but improved actually had a lower risk of subsequent MACE than those who stayed good. Perhaps what's happening is that they're having a lot of intervention thrown at them to reduce their macrovascular disease risk, which is a positive, of course. So that was the summary of the study that I presented today. Thank you.